Okay. Welcome everybody to this second session of the academic section annual meeting today. We've fortunately picked on quite a hot topic at the moment, and that is active surveillance in clinically localized prostate cancer. So I've got a couple of introductory slides which I'll share with you before we move on to our three very distinguished presenters. So in 2014, NICE updated their prostate cancer diagnosis and management guideline, number 175, and in that made recommendations for the suitability of patients to have active surveillance and made recommendations on what that surveillance should be. So active surveillance for low risk and some intermediate risk prostate cancer, the protocol for those patients should follow this schema here. So at enrollment, we would expect patients to have a multiparametric MRI if they'd not had one before they enrolled in active surveillance. And in the first year, every 3 or 4 months, they would have a PSA, a rectal examination every 6 to 12 months, and then a prostate rebiopsy at about 12 months. Subsequently, assuming all was stable, between years 2 to 5, they would have regular PSA measurements, annual examination clinically, but no mention of any more biopsies or MRIs at all, unless there was any concern, that concern not being well defined. ASCO made some recommendations in 2016, so just a couple of months ago. And their recommendations were these. So for most patients with low risk prostate cancer, Gleason equal to 6 or less, active surveillance is the recommended disease management strategy, but also may be appropriate for some patients with low volume intermediate risk disease, Gleason pattern 3 plus 4 equals 7. The monitoring or surveillance of such patients was given here. So a PSA test every 3 to 6 months, a rectal examination probably at least once a year, and then a further prostate biopsy, at least 12 core, within 6 to 12 months. And then serial biopsies every 2 to 5 years. So that was a rather different kind of recommendation to the NICE guidance. And treatment should be considered if repeat biopsy shows Gleason score equal to or greater than 7 or increases in volume. So where are we at the moment in terms of surveillance or deferred treatment? I think we've probably got 3 main ways in which it's being done in the UK currently. There's watchful waiting, which is been around for many, many years. So watchful waiting, I think what we mean by that is deferred treatment and treatment in terms of palliative intent, mainly with androgen deprivation therapy. And then we have active monitoring. So this is a term that really came about, I think, as part of the PROTECT trial. So within the PROTECT trial, which began 12, 13, 14 years ago now, within that trial, the active monitoring arm included mainly PSA surveillance. There was no requirement to have MRIs done, either at the outset or in follow-up, and no protocol biopsies were scheduled. So that's a slightly more relaxed way, I think, of surveillance, but the treatment intent was still curative. So if there was evidence of progression by PSA changes or clinical changes, re-evaluation would occur within that trial. And some departments, including ours in Cardiff, adopted that as a way of carrying out surveillance. So that was termed active monitoring. But I think for most people in the UK, particularly after NICE guidance, they tend to follow a more regimented approach for young men. So that would be protocoled MRIs, probably, protocoled rebiopsies. So these are areas which we are going to focus on this morning, mainly active surveillance. So we've got 3 distinguished speakers who've been closely involved in work within this field, and I'd first like to call on Professor Dan Burney from Barts, who's going to talk about pathology. Thank you.
Thank you, and thank you very much for the invite here as a pathologist to speak to you all today. So a bit of a controversial title. I'm not the first one with a controversial title today. Grade groups is the end of Gleason scoring. And what I want to talk about is the lower grades, are they cancer? And can we better define low-risk disease? A bit on intra-observe error, and also importantly, what you need from your pathologist, because this world is changing probably slightly faster than you realised. Now, the original sort of benchmark we had was in 2005, was an agreement by ISUP on Gleason scoring, and they did change some things. I'm going to bore you a little with pathology today. They did change. Have I got an? I'll use my mouse if I can. Aha! They did change some of the grading of cribriform lesions here, changing some 3s to 4s and upgrading some areas. So there were defined patterns that were used in 2005. Now, a number of us had a lot of problems with this system and thought it was slightly substandard. Jonathan Epstein wrote an article that was very, very highly quoted and highly cited and talked about. I wrote 2 articles which were widely ignored and no one talked about, but they basically said the same thing. There was a case for modifying the Gleason PSAD system. So what are the problems with Gleason grading? Well, we know that 2 to 5 are no longer assigned and not viable entities, as I'd originally said in my article. The second thing is that 3 plus 4 equals 7 does not equate with 4 plus 3 equals 7, and this is very important for active surveillance, as we'll see. And the lowest is 6 on a scale of 2 to 10, which is basically madness. And we did a study on the variation of Gleason grading, and we found out that among 266 pathologists, there were still some areas that were causing variation in pathological assessment. And they were mostly on the area of irregular cribriform, smoothly rounded cribriform glands. 50% called them 3, 50% called them 4. And this wasn't really successful. Some people were still using lower grade cancers. And also some of the risk classifications are now out of date. I don't think there's anyone that would argue that Gleason 7 is satisfactory as a category. Is there anything we can do about this? Well, this was really led by Jonathan Epstein at Johns Hopkins, and he tried to divide the cancers into 4 different groups in an article in BJUI about 3 years ago, and calling them grade groups 1 to 5. And he showed that these 3 plus 4s obviously had a much better survival in a radical prostatectomy than a 4 plus 3s. And there was also an evidence base in terms of the patterns you see as well. The problematic cribriform pattern was in fact shown, even in rounded forms, to behave more poorly than expected, even though some people were still grading it as 3. So that could mean an overactive surveillance problem. And these are glomeruloid areas, and they were also sometimes called 3, when in fact we now think there's fairly good evidence that they had 4, are grade 4. So in 2004, we had a Vancouver meeting to reassign some patterns, have some clarity on difficult issues and creation of grade groups. I will be the first to tell you now that this was a somewhat difficult meeting. The world of uropathology in the international is really a bit like Game of Thrones, but with a bit more violence. So it was a difficult thing to sort out. But we did come to some firm consensuses, in that these cribriform areas are now pattern 4 and all glomeruloid are pattern 4, so taking these out from the active surveillance category. And so we've made a nice new pattern, which I won't bore you with, but we've changed the rules slightly. And we have also changed 1 and 2. We said that patterns 1 and 2, and it was slightly doubtful in the last one, should not be given. So in your grade reporting rule, if your pathologist now gives a Gleason score less than 6, question or ignore it. It really has no relevance these days, and they're not viable as entities anymore. Well, I wondered whether to show you any pathology, very briefly. My mentors as surgeons were 2 great urologists, Bill Hendry and John Blandy, and both of them could question me severely sometimes on the pathology I was showing, and I wish that happened more nowadays. So in deference to them, I will show you a small amount of pathology. Rounded glands are basically Gleason 3. Irregular cribriform glands and regular cribriform glands are Gleason 4 with the fused patterns, and we've now got there's a wonderful paper out that can show the 3D imaging of these using fluorescence in histopathology. And Gleason 5, there's a number of different things, but it's basically solid nests. Now, there are a few rules now that are important for you in this new Vancouver classification. There are no tertiary scores in biopsy. If a biopsy says 3+4 with a tertiary 5, question it. It should be 3+5. It's the most predominant and the worst score. So tertiaries are wiped out in biopsies. They are allowed in radical prostatectomies if less than 5%. And we also have made some more rules in different variants. We don't grade small cell, it's different. We don't grade intraductal carcinoma, which is a relatively new entity. And we grade ductal as 4+4 equals 8. Now, to move on to this important area of grade groups and why we're introducing it. So as you see, this is the correlation between Gleason score and grade groups, in that Gleason 6 now becomes grade group 1. I personally think it's much easier to explain to your patients, you have a grade group 1 on a 1 to 5 scale for active surveillance, rather than you have a 6 on a 2 to 10 scale. It's madness. So I'm hoping that using grade groups will be of assistance to you as clinicians. There's also the 3+4+4+3 group. Now, this has a big evidence base about it. This was a paper that came out last year in European Urology, led again by Jonathan Epstein, but it was a synthesis of radical prostatectomies in 5 huge cohorts. We're talking 20,000, 30,000 patients here, using biochemical relapse as a surrogate for outcome. But you can see, first of all, even in radical prostatectomies, a few of the grade group 1s, 3+3s, did recur, but not many. You can think of it as about a relapse rate equivalent to papillary thyroid cancer, or to be cheeky, seminoma, which we still think of cancers. So personally, that's why I still think that 3+3 needs to be considered a cancer, though I know that some people in the audience disagree with me. Grade group 2, the 3+4s, still do very well. But look at the difference between the 4+3s and the 3+4s. There's a huge gap there, and both considered Gleason 7. So can we consider, as Howard said, active surveillance between grade groups 2 and grade groups 3? The third thing to say is, of course, how well. We tend to think of 8 and above, bad cancer, go away. But look how big the separation is between grade group 4 and grade group 5 is. So it's really, really detailed. And I'll show you how detailed it is with other studies in a minute. Gleason scoring, or scoring of cancer, is a very powerful technique. This is my own data, which appeared in BJC a couple of months ago. The reason why it's important is that it's basically a watchful waiting series from the 90s. So we have long-term follow-up, and I grade grouped them all. And you can see here that even using this data on 1,000 or so cancers, it was about 980. First of all, grade group 2 and 3 still separate very well, and grade group 5 and 4 separate very well as well. They all separate very well. The closest ones are grade group 2, grade group 3, and grade group 4. But there's still a possibility of active surveillance in these two groups here. Now, something that's often said about pathologists is that we're not consistent, is that there's a lack of standardization. And it's true. There is intra-observer error between pathologists, but one has to question how bad this intra-observer error is. This was a standardization study we did a couple of years ago. And this case was, case 1, 80% called it Gleason 3, 20% called it 3+4. Now, they might have seen small areas of 4 that the others didn't see. So there's a bit of balance here, but the spectrum is not huge here. That I would call the preferred Gleason score, whereas that is acceptable. These people here clearly aren't doing their job very well, the small ones here, and need to be rectified. As in any discipline, you'll get people who don't interpret scans or don't interpret or don't do RPs very well, dare I say. And the same here, you've got a split between 3+4 and 4+3. The rest are clearly wrong, but these two, is it that bad? Is there anything we can do to sort out these minor degrees of intra-observer variability in Gleason? And I think we can. And we can do this by considering the percentage of Gleason 4 in a tumour. This is still a wide spectrum. And if you have minimal amounts of 4, obviously it's going to change people from a 3+3 to a 3+4 that might dissuade you from active surveillance. What data do we have that percentage of 4 is a useful adjunct? Well, there's again been some good papers on this. This is an amazing paper by Guido Sauter, who looked at the percentage of Gleason 4 in his cohort. And you can look at how well this stratifies very, very sensitively in a series of about 12,000 cases for biochemical recurrence on the whole. So the amount of percentage 4 is important. In my own study, it does, in fact, come out very, very well. I looked at the percentage of 4, 5, and this is at the bottom, there's percentage of high-grade disease from 0 to 100, and at the top, there's the risk of prostate cancer death. This is unpublished data as yet, though I have abstracted it. And it works for Gleason 4 in percentage of Gleason 4 in 3+4 and 4+3s at a very high significant level. And to my amazement, it even had prognostic significance as the percentage of 5 in the 4+4s, 4+5. Now, this is an active surveillance talk, but this is important for something like Stampede, looking at biomarkers, when the percentage of 5 might actually be important. So, in conclusion, percentage of grade 4 may give valuable prognostic information for potential active surveillance, and it may be especially useful in those borderline cases where pathologists sometimes are a bit wet and go, it's 3+4 because I can see a bit of fusion. But if it's only 5%, one could say, well, maybe we can actively survey this patient. So this is just how I report them nowadays. Prostate biopsy partially replaced by an adenocarcinoma, Gleason score 3+4 equals 7, grade group 2 with 5% grade 4 and with a measurement and a percentage. Now, I want to move on a little bit to how to biopsy reporting. Should you be using the worst or overall grade of cancer and reporting tumour involvement, which is obviously also important in active surveillance criteria. What do you do, for instance, if 6 of your cores show Gleason 4, 3+4 equals 7, and 1 shows 4+4 equals 8? Do you use the worst? Do you use the overall? Well, if you speak to the Americans, they have a very good job at passing the buck, because they get billed independently for their biopsy results. They just report them all independently and very rarely come up with a synthesized Gleason at the end, which pathologists try to do. I'm very in favor of this. I think our job is to interpret what we see in these biopsies and give you an overall grade for the case, which is trying from the biopsy to estimate the overall grade in the specimen. I think it's an abnegation of responsibility if we don't give an overall grade. You might think it's the worst grade, you might think it's the overall grade, it depends what you see. If you think of yellow as 3 and red as 4, then this is obviously a 3+4 cancer, but there's a tiny amount of 4+4. So maybe we should be giving a 4+3 and not the worst score on for these tiny groups of 4 here. Maybe that's the best way to go. I must say the evidence here is still not quite there. Some people still use the worst. In our new recommendations, which will be coming out, we'll just say be practical about this. The second beef I have with the measurement system for grading and the percentage grade is these two cancers have identical lengths, as you can see the yellow bits here. But one is less than 50% of the core, and one is far more than 50% of the core. And this is the trouble with percentage involvement. You're defining the cancer by the amount of benign tissue you get. So basically, you're defining it by the amount of digging that the truss biopsy or parametric biopsy, or however you do it, does. So I'm not a fan of percentages, though every time I don't give it, everyone throws their hands up and said, oh, we need it for trials and things like that. I say, okay, have it then. So I give the percentage. But I think length of cancer is a far more powerful figure and tells you far more, 4 millimeters, 10 millimeters, whatever. So all pathologists, as you know, have OCD. But some are more OCD than others. And I promise you, I stand here as the least OCD pathologist you will ever see. And one thing we're getting in the new system is to stop this 3.2 millimeters length, this 32 percentages or whatever. We can't be that accurate, and we shouldn't be trying to do. We measure to the nearest millimeter, and we should give a percentage to the nearest 5 or 10. I think a lot of people try and over-quantitate to give you this magic thing we're doing. It's not magic. So it's very, very simple, really, measuring. And so you shouldn't over-quantitate. And pathologists who change other pathologists' report from 3.2 to 3.3 millimeters are doing no one any favours at all. So there's a critical role of pathologists, I believe, in determining eligibility for active surveillance. Having said that, I haven't mentioned the magic word MRI at all so far, but I do think, obviously, good pathologists realise the importance of MRI, and good MRI people realise the importance of pathology. We work together to determine what is best for the cancers. But I wanted to show you how powerful Gleason scoring and grade grouping can be in looking very, very specifically at prognostic information. And we can give you much more information than I suspect some of you are given in your reports. So in summary, grading has evolved in an evidence-based fashion, I believe. Older studies using grading should be queried because I think they lose prognostic information, and I actually think that they may overestimate other prognostic indices as well if they're not to current standards. I think the new grading system, grade grouping, is more helpful for clinicians in patients, and I think that more detailed reporting will be very helpful in active surveillance decisions, especially in those cases with a low percentage of Gleason 4. And the major thing we've got to do between pathologists, radiologists, and surgeons is to avoid misunderstandings. So I hope this talk will show you how powerful Gleason and grade groups can be, and how important it is to speak to each other in our regular practice. Thank you very much.
Thank you, Dan. We're going to take questions at the end of the 3 presentations. So I'll welcome Jonathan now to speak on the role of MRI in localised prostate cancer and active surveillance.
Thank you very much, Howard and BAUS, for inviting me to this meeting. It's not often that radiologists are allowed out of the basement during the daylight hours. So, and it was perhaps with that sort of sense of holiday euphoria that I agreed to this slightly controversial topic. So we'll agree that the statement that all you need for active surveillance in prostate cancer is MRI, or multiparametric MRI, is a rather stark and simple statement, and doubtless it is rather provocative in a room of urologists. So as likely the only radiologist in this room of surgical lions, this image came to mind. And I'm feeling a bit like Daniel there, that I have a little bit of an uphill struggle to persuade you that, that this is the right way to go. But hopefully in the next 25 minutes I will win some or most of you over. Let's take things down a temperature or two by just making sure we're all agreeing what active surveillance is. It's already been touched upon. It's an observational follow-up. It definitely has an intent to cure, but not necessarily right now, or even necessarily in the patient's lifetime. In other words, we can sort of just keep postponing the active intervention, which has morbidity or mortality associated with it. As I said, it's curative in intent. And we have, nevertheless, with that in mind, to continue monitoring the disease progression and to see if it then does upgrade, or if there is some reason in the patient's either wishes or in the patient's biology that means that this strategy of deferring is senseless, and that if we continue to defer, rather than putting the patient in a better outcome, we will put them into a worse outcome. So with that relatively simple strategy in mind, as Howard said, we drew up a set of guidelines in 2014, and it wasn't just pulled out of the hat. It was based on a survey that was sent out to support us by the NCC in 2012. We got 19 networks of 24, 63% return rate. And this is what was culled from that survey. It's quite interesting. Quite interesting. I'm told the pointer isn't working, and it isn't. Top part. I'll go back a slide. Right. We'll use the mouse. I think that's what other people have done. And the mouse is working. Doesn't matter. Doesn't matter. We're good. We're fine. We're fine. Thank you. Look at that. Right. Fortunately, everyone does agree that T-stage is important in defining whether you go on active surveillance, and it's T2 or less. 11% didn't think that Gleason was important at all, which is quite interesting. But of those that did, it was split between 6 and 7. And as you've heard already, 7 doesn't mean 7. I call it 7A, 3 plus 4, 7B, 4 plus 3. They're different. So already we're running into some problems here. PSA, amazingly, 16% doesn't use that as an evaluator in putting people onto active surveillance. But if you do, 50% a PSA of less than 10. 16% you can have a PSA of less than 20 and still be considered on active surveillance. And the cause involved, and we already heard why that is a bit of fallacious data, and we'll come back to that a little bit more. 32% thought that the cause involved should be considered. In that, there's relatively consensus. Once you actually get to what you do afterwards, it's anybody's up for their own idea. PSA on different time scales, rebiopsies annually, within 18 months, within 2 years, your own pattern, doesn't really matter, doesn't seem to be an issue. So we have a bit of chaos in this. So how do we take something, extract something out of that haphazardness? There are some data here. This is a big study, 24,000 plus men and a meta-analysis. They came up with 3 things that seem to be important on predicting whether you were going to progress on active surveillance. The prostate-specific antigen density, the density. I'll come back to that on several times in this point. 2 positive cause and race. These were not thought to be indicators in a big meta-analysis of going up to whether you were likely to upgrade and come off active surveillance. There's the reference. If anyone's got your phones out, I'll leave it up there for a second. And I want to just draw your attention. We'll come back to these 2 positive causes in a minute. Now, the PRIAS study has also got a decade of results out, so we should look at those. 5,000 more men. They rebiopsied people at various points of the survey. I think it was 1, 4, and 7 years. At rebiopsy, you were reclassified according to whether your Gleason grade went up from 3. They took 3 plus 3 as eligible. Above 3 plus 3, you weren't eligible. If your Gleason grade on rebiopsy was more than 3 plus 3, or if you had, again, more than 2 positive biopsies cause, you were reclassified as coming off active surveillance. And it was relatively stable. It didn't matter which point of the journey you were on at the 1st, 4th, or 7th year of biopsy. It was about 30%, about. 52%, therefore, discontinued at 5 years, 73 by 10 years, based on these reasons for coming out of the study. Mostly these reasons. A few people decided to come out anyway, but basically these figures are pretty accurate. And then of those, this is very interesting, if they then went to radical prostatectomy in coming off, greater than 2 positive cause was not predictive of unfavorable pathological outcome after all. So having been told that it was, one of your mainstays in deciding why you should decide and you shouldn't be helped by MRI has been kicked away. The stool's been kicked away. The PSA density continued to be a good predictor. This is the PSA doubling time. I don't want you to think that that's density. That was not a predictor. So PSA kinetics has been kicked and cause positive has been kicked. Gleason still sticks in there. So let's try and use this on a modelling study that has been done. There's the reference. This is the modelling. And they're saying, and I'm going to get to MRI in a minute, they're saying why we should nevertheless, despite all of these uncertainties, why we should continue to use active surveillance. If you are low risk, your probability of overtreatment is about 70 to 80%, down to 40% if you're on active surveillance. Intermediate risk, these are the figures, and obviously for high risk, you really shouldn't be on active surveillance in the first place, so that box is out. So, but you can see, therefore, why active surveillance, despite its uncertainties, despite no one really agreeing what it is, and despite no one being absolutely sure, based on clinical data and pathology data, who should be in, you can see that it isn't a bad thing. And as you've seen this slide already, recommendation for low risk, you should offer active surveillance. Intermediate risk, you should consider it. That's the recommendation that you should be working to. So where we are at now is this. You suspect someone, you biopsy them, you might do a trust, you might do a transperineal, you get a PSA density, you get a Gleason, you get some core data. We've heard already the core data are rather spurious from a pathologist's point of view, and you make a decision. You talk to the man, you decide on various things, you look at their clinical assessment, their risk factors otherwise, their overall things. You get a PSA density, and you get a Gleason grade, which is great, except it isn't great at all, because the biopsy data are limited, very limited. Why are they limited? They are limited because it misses significant disease. It's a geometric test. You do a trust biopsy. I'm sure most of you in this room are sitting here because you treat prostate patients. You probably do the biopsies yourself. When you do a biopsy, what you're doing is firing into a pattern that you've got a very well established. So this idea of random biopsy, it's not random. It's not at all random. It's very systematic. You have a very set pattern of how you're going to biopsy, schematically shown here. The problem with that is it's a geometric pattern. It has got nothing to do with where the tumour is. Majority of tumours in men with PSAs less than 10 or 15 is not visible. And yet, there it is. You missed it. There it is. You missed it. There it is. You missed it. Not because you were bad. You couldn't see it. How could you hit it? It didn't conform to the pattern that you chose. So trust biopsy is giving you data on which you are making a fundamental decision that's just wrong. And what's more, if you do hit it, you might just skim it. So of course the pathologists are going to have trouble. You've missed the high Gleason grade, or of course this is going to look like a small percentage of core, or maybe even this core divided into two, because it did. And now my pathologist is getting a bit of tumour in one, hardly any in others. He's going to call me 3 cores. I need focus of Gleason 6. Forget it. Active surveillance. You've made a mistake. So we have rationalising the haphazard. We're telling you to put people onto active surveillance, but we're doing it on data that's not very good. So I suggest let's take away the scheme, and now let's talk, finally, you've come to hear me talk about MRI. If you do an MRI and it's negative, and we'll come a bit to what negative means, you can put them onto PSA active surveillance, you can keep them under review, you can put them onto active surveillance to all intents and purposes, just they haven't got a cancer yet. They may never have a cancer, but you haven't done them any harm, they're on the pathway. If it's positive, you biopsy them. You might take a systematic biopsy, a targeted, additional, I call it Trust Plus. You might do a focal biopsy, you might do transperineal. It doesn't matter, we don't have to argue about it, we can figure that out locally, what's best for the patient. Now you have a PSA density, you have Gleason, you have core data, which is a bit meaningless because you might have done a focal biopsy, but it's much, much more reliable data because you've used it based on another bit of information that's helped you. If you do the biopsy first, you're here, but now you put the MRI in, like it says in NICE. You put the MRI in. If it's positive, then you look, does it correspond to where I know it's positive, because I know they've got cancer, or does it not correspond? In other words, maybe there's something else that I've completely missed. I've missed the thing that's positive because it's a low-grade Gleason 6, truly, that's what you found. But also the biopsies missed this. They missed the one that's positive MRI. And if it's negative, that's very reassuring because the MRI has shown nothing. The Gleason grade, this biopsy is relative negative. I'm quite happy. What is MRI? I wasn't sure whether I'm patronising people here, so please bear with me if you know all this. But I did hear some things earlier today that made me think that perhaps it is worth including. First of all, I'd just like to say spectroscopy is not part of multiparametric MRI anymore, and it hasn't been. T2 is fundamental. Diffusion-weighted imaging is the cornerstone of the functional sequences, diffusion-weighted imaging, done properly in a unit, and we would be very happy to advise radiologists if they're struggling to work out the best units. But there are papers out there on best practice. The ADC map and dynamic contrast imaging, that's been hot and cold. I've blown hot and cold about it. You don't have to have it, but I think if you're doing it properly, I've come back finally to the decision that it should be included. So it's a Nike moment, just do it. These are the T2s. I hope you can see the lighting's really bad in here, but it's blacker there than there. Same patient. This is the ADC. This is the B, the high B value, very high B value, and the ADC black. ADC, D dark black. If you're being shown these in your MDTs, D dark on the ADCs bad, B bright, high B bad. Oh my goodness me. What I'm telling you there is that if you've got good radiologists there and experienced, and they work with you and they work with the pathologists, then you will get a relatively accurate report in detecting and localizing the cancer, and not only that, in assessing its likely level of aggressiveness based on these functional data. So it's questionable then. So I'm bringing it round. Here we are. We're saying you should use active surveillance if you can, but you have to be sure that they are low risk. And in that situation, I'm telling you, use the MRI in that evaluation of risk. Stop pussyfooting around and start using these pictures. Another multiparametric MRI in Technicolor to try and attract you to its utility. I'm really sorry that it's too light here. I have done the white writing on the black. That's the right thing, but I can't do the MRI white. It's not possible. They come out like this and you can't do anything about it. So you aren't going to see very well here. But here are two axial images, and this is a coronal image. They're the T2. There is low density here, low signal here. There's also low signal here. This is the thing that's biopsied. These are the ADC maps. Big black hole there, little black spot there. So D, dark, bad. These are the high B values, very bright here. You can't even see this one. I can't even see it, and I've got the computer in front of me. And what was biopsied and wasn't very important, happened to be biopsied, was this. So they were put on active surveillance. We did the MRI. We said, whoa, there's a big bad tumor here. This is the lightning strike. It was rebiopsied. So this is a case of active surveillance where the biopsies were fine by the geometric pattern, but you missed it. You found a pussycat, you missed the tiger. So this patient will not do well on active surveillance, I guarantee, because they won't die from this. They never will die from this. Of course they won't, because they'll die from this far too soon before this touches them. So you have to make sure that you've done a proper evaluation, that they are truly low risk, and MRI offers you that ability. You've seen this slide. This is the test. It says you should use MRI at the outset, if not done already. And I'm just magnifying that so that you can see what the point about it is. Again, it's suggesting that you should use MRI in some way. It's relatively vague, but in some way of follow-up. So MRI at the outset, I don't really think there's an argument to avoid that test now. It's because I'm telling you, it's showing you the tumours that you will miss otherwise, and it has a high negative predictive value. It leads to less people coming off AS if you do it, and it leads to less disease upgrade. You'll see all my references in 2016. I decided when I was doing this talk, I'm not going to do anything less than 2016. It's moving so fast that the data, and we've already heard from my pathology expert, that the data, our pathology expert, that the data are out of date as they're being published. So anything I reference is 2016. I would really be skeptical when you're reading stuff about MRI that's earlier than 2015. I would be skeptical. I wrote some of it. I can tell you don't believe it. Also, visible disease is a significant risk factor in its own right, over and above cause and Gleason and everything. We see something on MRI, you should take it seriously. So, the promise, of confirming truly low-risk disease. It was a study, I think Professor Emberton's in the room, and I know that he's going to be telling you about this much more detail. This is out in public domain. I have checked that it's okay to present these data. They were presented at a meeting a couple of weeks ago, and I hope that I've more or less summarized from the limited data correctly. But basically, it was an MRC, multi-center, very highly refined trial with 740, of which 723 went to completion, 193 cancers, based on at least 40 samples, I believe, depending on the size of the gland. But an exhaustive, as good as a radical prostatectomy without actually taking the prostate out. These are the data. I've highlighted 3. Sensitivity of trust, 48%. And you're basing your decisions on that. Okay, good. Sensitivity MRI, 93%. Do I need to say any more? I probably could stop now. I think you're intelligent. You'll agree, doubling it. Negative predictive value of MRI, 89%. We've done about 1,000 pre-biopsy cases. Also, we've analysed our data. We've held the publication back because I didn't want to send it out before PROMIS came out. But it's very much there. We were 92%. Of the ones that were missed, out of 193, there was one small Gleason, significant because of its size, but Gleason 6, 16 3+4s. Interesting, and very much with what we are hearing about the difference between 3+4 and 4+3. I made the distinction. 7A, I call it. 7B, none. I hope, if Mark says that, I haven't misquoted you, I hope. Okay, I haven't heard that I have. So it is a negative test. It's a good, oh, there he is. Is that okay, Mark? Were they pretty okay, the data? Yeah, okay, phew. So I say if you do the biopsy first, you do an MRI, you see no focal lesion, it's truly low risk, you can take the patient off, you can keep them on active surveillance. If it's a focal maps to histology and it's good functional data, you know, the ADC and all that are okay, lowish risk, you can keep them on active surveillance. If it maps to, but it's looking worrying, you've probably under-biopsied them. Consider reevaluate at the very least. I don't mean you have to biopsy them again, but you certainly have to say, we have to think about this. If it's a focal lesion that's not concordant with histology, in other words, it looks much worse than the histology, or it's in a different place, rebiopsy them, reassess them, then decide to put them onto active surveillance or not. If much better, please, everybody, the best a man can get, Gillette, MRI is done first, and you haven't biopsied them at all. Why is it better? Well, first of all, you can probably do about 30% people don't even need, 30% of these men don't even need a biopsy. Everybody's happy. The man's happy, you're happy, the pathologist's happy. ITU's happy. Focal lesion, indeterminate, intermediate, we call it intermediate. There's a PRIAS system. It doesn't really matter what you do, but you can't quite make your mind up. You could consider PSA and MRI active surveillance, or in exactly the same case, you could consider doing a biopsy. It doesn't matter what you do, and you don't have to make always the same decision. 72, PSA 6.3, 55, PSA 8.9, father died of prostate cancer. Okay, so there's more than that. Urology will make the final decision on this, but you will be basing your decision on active-based data. Focal lesion, biopsy it. Here's an example of why we therefore would want MRI and follow-up. I sense I'm running out of time. The PSA, it's an opportunity to repeat the biopsy. So if you have seen something on the MRI, there's the ultrasound. I couldn't see anything on the ultrasound, but when you see it on the MRI, you put the target, we do a biopsy, and we take the tumour, and we get the tumour. This is, you really can't see these pictures, but this is the needle going through that tumour. Another example of biopsy data, the MRI is showing nothing, the ultrasound is showing nothing. We biopsied this lesion, which we could see with the MRI's benefit, and we got a Gleason 7. So I've made the decision, I've made the case, I think, that you have to use MRI at least at the outset. Now there are arguments that it should also be used in surveillance. These are the papers. What else can we say? 2 other reasons why you should use it in surveillance over in place of biopsy. First of all, the chance of getting an infection is about 3%. It doesn't matter where you're biopsied at first, second, third round of biopsies, but it's still 3%. Once you have an infection, that's bad, apart from it's costly and it's bad for the patient. It also means once you have a complication, the men are much less likely to continue with active surveillance. So if you can avoid the chance of having a complication simply by avoiding the test that gives the complication, that's good. Also, I understand from the surgeons that I talk to that if we've done multiple biopsies, if you then do a radical prostatectomy, I think it's a harder surgery because of the scarring, I believe. So that would be another reason to avoid repeat biopsies. So your choice, this one or this one. My summation is that cancer should become a minority, but it's a shameful diagnosis to say that you've got T1C disease because you should be using a biopsy first. D'Amico is bust. This is the data for Gleason's by a year in 2009. Let's project to 2015. Let's stay at the same starting point, assuming nothing changed. and let's project what would happen if we do MRI. This is what I predict will happen. Gleason 6 will drop, Gleason 7s will come up here. I didn't quite know what will happen to Gleason 8s. They'll probably more or less bubble on at the same level. So back to the title. It's stark, but I will therefore concede you an almost. What I'm saying is that you need MRI as your mainstay for active surveillance, but you do also need to have the pathologists and the biopsies. It should act as a surrogate for biopsy, and your biopsy should be reactive to the MRI or changes, not to anything else. And therefore this is my final slide. Take a picture of it if you'd like. I want to just claim copyright. You can't see. This thing says copyright Richenberg, June the 1st, 2016. Why am I saying that? I'm saying that because about 2 weeks later, this came out. It's not been published yet, but the e-publication came out 2 weeks later, and it says pretty much what we're saying today. MRI is the best method to exclude the presence of high grade. In the near future, MRI might even be able to replace systematic biopsies. So that's from you lot, that's not from me. So, and there's it's not out yet, but it is in European Urology. So now, I'm hoping now that Daniel has tamed the lines and that I get a request form for multiparametric MRI rather than, no doubt badly filled out, but I get a request form, rather than for a biopsy. Thank you very much.
Thank you, Jonathan. So our final speaker is well-known to you, Vincent and Anna PRIAS from Cambridge, going to give us an update on where we are in terms of research and trials in surveillance.
Oh, do I? Yes, those pictures are making me nervous, actually. Well, it's great to see so many people here. It's a bit unusual for Monday and the academic section. It either means two things. It's a really interesting topic, or maybe there's nothing else going on out there. So I'm hoping it's the first, actually. And it's a hard act to follow when speaking after radiologists and pathologists who are clearly at the forefront of their specialities in terms of prostate cancer diagnostics, actually, risk stratification, and of course, eventually active surveillance. So I've been asked to speak about research and trials and surveillance, and it's probably fairly true to say that this is still at its infancy in many ways, because most of us have actually didn't want to jump ship from radical treatment to surveillance, because we all know about radical treatment. We know the outcomes are great, we know what they produce, but active surveillance was always that thing which we did and hoped for the best. And I still remember in BAUS some years ago when Chris Parker stood up and talked about his active surveillance series and how he was promoting that for low-risk disease. And a lot of people jumped on him and said, it's not safe, you shouldn't be doing it, producing lots of data to the contrary. So what changed, really? Well, what changed was our understanding that low-risk prostate cancer doesn't kill people. In fact, not just low-risk prostate cancer, there are a lot of prostate cancer. And this is data from untreated patients from Sweden. It's a Ryder paper from the European Urology some years ago. And green and blue outcomes related to prostate cancer is in orange. Green is other cause of death, and blue is cardiovascular death. And you can see across age groups and across risk types who dies of prostate cancer, who doesn't. And it's really only when you start to get to these high-risk categories here, and this is all old-fashioned stuff compared to what we know now, you start to see that prostate cancer deaths starts to outstrip other causes of death. And this is a very important issue when you're counseling people about the concept of not treating versus treating. It's actually much more difficult to not treat somebody than it is to treat someone. And we have a lot of data showing how overtreatment has been a big problem. This is, again, some old data from 2009, the States. The big box is the sorry, that's not my slide, so I'll put all the bits in. Outside is all the population. This box in the middle is the number of clinically detected, so clinically detected, not screen detected. And then the number of deaths is just this small box in the middle. But of course, all these people would have been treated. And of course, the much maligned PIVOT trial, which published an observation versus radical prostatectomy study and showing no difference in survival except for very select individuals. And what's really changed, and that's what's really made the shift for us, is that we are much better at ascribing risk. Because in the end, when we talk to our patient about what they should have, it's about their risk, isn't it? That's how we decide in MDTs. This is what we tell people. And as we've seen already, the biopsy strategies have changed incredibly in the last few years. From the standard trust sectoral template biopsies using the grid maps, and now to very highly sophisticated image-guided systems. And this has happened in the time that I've been a consultant, because when I was a last year trainee in Newcastle, nobody heard about this stuff. But it's pretty intuitive. Most of us are doing it. It's not going to go away. This is how it'll be done in future. But surveillance, or perhaps non-treatment, has been going on despite all of this. This is a paper we published from our Eastern Cancer region, which demonstrated how changing management has occurred over the last 10 years. And if you look at the low-risk category here, this blue line represents active surveillance of watchful waiting. It's not a gradual go up, it's a massive exponential go up in what's been happening. So already we are starting or have been not over-treating patients in the UK. And this is before lots of the evidence which actually came out after this period of time here. Again, other trends you see is a drop-off in the use of primary androgen deprivation therapy, which used to be a very popular treatment and is now increasingly something we do selectively. So what about research activity? Well, this is a chart which shows the AUA 2016 active surveillance abstracts, which is interesting reading because, I'm sorry, it's a bit small here, but this is insurance and cost effectiveness, very big thing for them. Variations in practice, about 2 abstracts. Entry criteria, 12 abstracts on that. Biomarkers, 4 abstracts. Drug interventions, 1. Rate of intervention in correlation with histology, 9. Biopsy and histology, 5. And imaging, 6. And in this meeting, we've got 1, which is actually from Howard, from your group. So despite the fact that we have actually probably led on active surveillance with Chris Parker and the Marsden, don't seem to be producing or presenting a lot on active surveillance in this meeting. Other than that, all the abstract selectors have decided not to choose it. But you can see the spectrum of interest here. So what about research in active surveillance? What are the questions? So I suppose the first one is, who is suitable for active surveillance in a changing paradigm of risk? And we've heard 2 talks here on how risk is actually changing. The other question, how do we standardize active surveillance? I mean, radical prostatectomy is radical prostatectomy. You whip the prostate out, lots and lots of discussions, millions of papers on how to get your margins and all the rest of it, but it's the same procedure. Radiotherapy, lots and lots of papers, but in effect you give radiotherapy to the prostate. But how do you standardize active surveillance? What's the best way to monitor people? Well, it's all very well saying let's go into active surveillance, but then what do we do with them? We're suddenly going to have thousands and thousands of men who are living longer and longer, all being surveyed. And we do not have any method right now or infrastructure to actually do this. The simple solution? Discharge them back to primary care. But we know in our region, and I'm sure many of you know in your regions, the GPs are not interested, cannot manage, do not understand the disease. So you send it back and you say, please refer back if the PSA goes up above whatever, by whatever, you get a letter back saying it's gone up by 0.2. Do you want to see him again? And that's what's going to happen. We cannot devolve this to other people. If we are going to create active surveillance as a management option, we need to have the responsibility of doing it. What about biomarkers in active surveillance? This is a classic place where biomarkers would be useful. I've never really understood why you need biomarkers in surgically treated patients if the prostate is out, because the disease is different. But in men you're not treating, now this is really where it's interesting, to track and to have a way of monitoring how people are changing, or the disease is changing non-invasively. That could be imaging, that could be bloodborne, it could be ctDNAs, it could be whatever else you like to look at. And really, the really interesting thing is that it? So we decide not to treat somebody, and that's it, we're not going to treat them. And if something goes or progresses, we'll just shift them back to the old treatments. I don't think so. I actually think that this is an opportunity for an entirely new paradigm in treatment, which is to say, can you change the natural history of this disease so you make it a chronic condition that never actually needs to be radically treated? And that is something which I think we really need to think about. So expanding the population suitable for active surveillance. Now we've just heard somebody say there, well, Jonathan yourself actually, that in the future we will not be diagnosing Gleason 6, therefore surveillance numbers will go down. Very possibly. However, we will actually create a new thing, which is surveillance for a new breed of intermediate risk cancers, which actually are probably indolent. How is that going to happen? Because of the new ISA prognostic scores, which are redefining risk, and precise imaging as well. And also a growing body of evidence that Gleason 7 active surveillance cohorts are actually doing pretty well. Now, we still don't understand how to properly characterize and integrate histology and MRI to create an index of risk. At the moment, we're still using stratified systems, individual systems, pathology and imaging. We need to be able to put it together. And the tools are becoming very sophisticated, but they are not, at the moment not talking to each other very well. And we still don't know how to evolve that change or to monitor that change. So it's all very well having a definition for pathology as to what is significant or indeed imaging at the point you start your surveillance. But then what happens with the next biopsy or the next MRI? At what point is an imaging change significant enough for you to change treatment? We have no definitions for this, and we are all just feeling in the dark here. The minute you get an MRI which says something slightly different on another day, which actually could be a repeatability issue, we quickly run to get another biopsy, or we tell the chap, look, something is going on here, not quite sure, maybe you better have that operation now. So we've got all these tools to play with, but we don't know how to use it. And we actually don't know what the impact of using it is on the long term. But we're starting to see some real progress. This is Dan's paper, which he spoke about here. And then, very nice because you've actually linked this to death, and I'll come to that in a minute. But you've been able to show that using the new prognostic system links it to death from prostate cancer in a watchful waiting cohort. So this is actually something we should be using. We also have been looking at this, and we are just about to publish a paper where we've integrated the new prognostic scores together with PSA and with clinical stage into a new risk model which outperforms NICE in predicting cancer death. So this model now, we think, is an example of how you can start to better refine selections. This is a cohort of over 12,000 patients which we've put into this with follow-up about 7 years extending to 9. And this new stratification system identifies a new grouping here, which is actually intermediate risk cancers with other features which are intermediate risk, which actually perform pretty well over time. You start to see that change with 4+3. This is the 4+4s and 8s together with T3s. And this very high risk group, which is not the topic of discussion today, where we are currently not really hitting the targets. So I think that surveillance is going to become an increasingly attractive option for patients who are not the low-risk T1Cs, but actually the intermediate risks where previously we would have defaulted to treatment. But that group is going to need very comprehensive and careful monitoring with all the tools we've got to pick up those changes which will lead to an event. So what about how do you do surveillance? Well, some of you may be aware of the GAP3 initiative from November, which is an international collaborative which has tried to bring together large data sets of surveillance, and the UK has London and Cambridge as 2 sites. And some of the early outputs were really to try and understand what is the variation going on. And you can't read these slides, and they're in publications. But in short, you can see that if you look at all the guidelines, these are all guidelines, they all have some slightly different variations on what you should include in an active surveillance cohort. You can have risk category, clinical stage, PSA, biopsies, density, positive cause, extent of cause, minimum cause, all sorts of things actually, but none of this is standardized. And from one unit to the next, the definition of some of these factors, particularly the pathology, is going to change. And we have no MRI in this as yet. If you start to then ask yourself, or ask what do people use as criteria for actual change, then it becomes even more murky. And again, lots and lots of different variations and definitions on what is used. So if you were going to try to do a randomized trial to see which protocol is best, is it feasible to do one? Well, actually, the problem is the natural history is so long. Do we use radical prostatectomy histology as the endpoint? And many papers have come out saying men who have active surveillance and then radical treatment actually have worse pathology than before. Well, duh. I mean, you've just let the disease grow to the point where you treat it. So clearly you're going to have adverse pathology. But that doesn't mean that that pathology was actually going to affect the patient, because the link between a progression and a clinical outcome of death is actually not as strong as we think it is. Now, this is an example of a study which is being attempted, and this is the SAM study. And they're looking at a randomized study of 2 different schedules for active surveillance. I won't go into the details. I'm not sure how it's recruiting, but it is an example of how you can take men at inclusion, put them into 2 arms with different levels of follow-up, one less intensive and one more intensive, and see what the outcome here is, which is effectively change to treatment or eventual clinical outcome. But this study is going to have to run for 15 years before we get an answer. And by then, we will all have changed practice, a bit like probably what's going to happen with the PROTECT study as well. But we have to try something. But in the UK, we are not doing any randomized studies in this regard just yet. We have seen a slide on the PRIAS study, and the PRIAS study is visionary in its way. It's been collecting a cohort data really on active surveillance, and we've already heard that the outcomes show that it's actually pretty good. What about the NICE data? We've seen this table a few times. I mean, in the lack of any other guidance, it's fine. But actually, it's flawed because it tells you to tail off surveillance as you get longer in the pathway. But where do events happen? They actually happen later in time. In fact, the best time for you to do nothing about things is actually here. So there is an argument to say, you get someone diagnosed low-risk cancer, discharge them, call them back in 3 years, and then start to look after them. Because that's probably when something is going to happen. But it's a little bit risky to do that. Who's going to do it? And we don't understand the natural history. And we have to remember that all this kind of data was actually based on previous data with underrepresentation of the disease, lack of good biopsies, no MRI scans, and how does it actually map on to the new era of targeted biopsies? Because even if you don't do an MRI pre-biopsy, if you have low-risk cancer, you're going to do an MRI and probably another biopsy. Now, then you select your patients, and those guys who come through that gamut are actually highly selected, good disease parameters, and they actually do very well. We've been doing this in Cambridge for some years, and I can tell you that the number of men who come off surveillance after that pathway is minuscule, and that's at about 3 years. And I'm sure that's going to be mirrored across the way as well. We've seen a little bit about imaging, and really, there are some very interesting things coming out. This is a very new paper, just coming out in the next month or so from the Marsden group. And what they did was 9 years follow-up, looking at ADC values in terms of predicting patient outcome. And patient outcome was defined here as time to therapy or time to disease progression on a repeat biopsy. And they showed that ADC values above a particular median seem to predict those outcomes. But of course, you know, this, although was visionary back then, is 9 years old and doesn't actually produce a cutoff as to what an ADC should be. So it's a tool, or it's a paper which tells us we can start to use MRI more intelligently. And we have a number of refinements coming on board. Diffusion kurtosis imaging, where you can do some really nice images of where tumors are, tensor imaging, we've got hyperpolarized carbon coming on board, all telling us a little bit more about the dynamics and metabolics of tumors, which we can monitor and change. But this is all very much in its infancy and yet to be proven to actually affect clinical outcome, which is prostate cancer death or metastasis. And that is a big problem, because none of this is going to show validation for some years to come. What about molecular classification? Well, we have a huge understanding now of how to characterize tumors phenotypically, genotypically, and how these tumors may evolve. And we are clear now that there are classifications of disease based on that kind of genomics. But what I fail to understand is how this translates into treatment selection or indeed progression. Because it's all very well to know about how and which molecules come into play, like TMPRSS2, ETV, P10, CHD, all of these things in the progression. But how does that actually alter what we do about a prostate cancer? So there are some suggestions that we might use P10 status as an example. This is one of the most potent tumor suppressors in prostate cancer to guide when a Gleason 6 is actually an aggressive one waiting to turn, whereas one which is not waiting to turn. But we still don't know whether we've hit it correctly with the target and whether or not that event will or will not happen. So maybe circulating DNA non-invasively will do that. We'll just have to wait and see. In the meantime, what do we have? Well, what we do have is lots of companies out there who are knocking on our doors wanting us to buy their biomarker panel because it's lucrative, not because we know for sure that it's going to change anything for a patient. So a few of these, Oncotype DX, Polaris, ProMark, all good markers because they predict a risk, but they've never really been tested to completion, meaning to say people haven't done it, made a decision, watch to see how it happens. And we need to understand whether or not these new era of biomarkers are going to work when we've incorporated sophisticated techniques such as repeat biopsies with imaging and MRI as well, because they were all based initially on trust biopsies and imprecise understanding of disease burden. Also, which would be your favorite signature? If you actually look at how many genomic signatures overlap, there is very little overlap actually. All of them come up with slightly different categories of what is risky and what is not risky. And we don't really know which is the best thing to do. Now, very importantly, it's all very well to watch people, but we need to understand whether or not we can intervene to change that natural history. The understanding of how a grade 3 becomes a grade 4 or a grade 5, or in fact, if it does at all, is actually pretty poor. So if we can intervene in these steps, we might be able to stop anyone ever having to have a radical treatment. And there is some evidence of this already. If you look at the 5-alpha reductase inhibitor studies, 2 of them which published and show that if you take 5 ARIs, you can actually impede progression. And also now newer agents such as enzalutamide being used to show that you can shrink tumors and basically reset the clock. And if you reset the clock, then maybe that cancer will never actually progress into anything significant. And indeed, in the last year, there has been an explosion in trials trying to do this. If you look at clinicaltrials.gov, you've got hormone-based studies like enzalutamide, dutasteride, leuproleurin, 3 studies on exercise, 2 immunotherapy studies, including one from Oxford, and a number of different dietary products which people are trying in active surveillance studies, because it's the perfect setting for it, and a number of others as well. But the clinically relevant endpoints, as I've mentioned before, are the big problems. Survival is not really realistic. It's too far away, and you're not going to get funding to do this kind of research with that kind of outcome. Radiological progression, yes, but do we know that that kind of progression actually means an impact on survival? Histological progression, yes again, but what kind of histological progression, how much of it is relevant? Clinical progression, fair enough, changes from surveillance to active treatment, and our tools are becoming sophisticated, but they are still not yet integrated. And the events are probably very far in the distance. So, in terms of where we go, well, I think we've heard already the pathways are changing. This is the old pathway, and I think this is where we're heading to, which is much more sophisticated screening, image-based detection, molecular classification, and then perhaps an integrated patient profile and an MDT, which then allows us to select our patients appropriately. And surveillance will be part of this paradigm. So I'll end there by saying that certainly surveillance is here, but I think it's still a road under construction, and all of us have a part to play in how it's going to look like in the next 10 years. Thank you.
Thank you very much, Vincent, for that thought-provoking presentation.